In conjunction with this hearing, I am releasing an interim report titled, Unmasked, How Biden Health Officials Purposely Turned a Blind Eye Toward COVID-19 Vaccine, or I call them injection, injury, safety signals. I urge everyone tuning into today's hearing to read the full report to determine for yourself how the title is as accurate as it is incriminating. To set the stage for what follows, let me remind everyone that Dr. David Morans, now indicted for this, under conspiracy and destruction of records charges, he was an advisor to Anthony Fauci, emailed to colleagues on how to evade Freedom of Information requests. Quote, I learned from our FOIA lady here how to make emails disappear, and how he wanted, quote, correspondence on sensitive issues to be sent to me at my Gmail address, unquote. Included in this report is additional evidence of how federal health officials avoided creating a paper trail to prevent transparency and public disclosure. In discussing how they've been warned of a major limitation of FDA's data mining system, one senior FDA official wrote, quote, we should meet internally. Many considerations not suited to email, unquote. Other federal officials appear to have openly acknowledged that they were actively attempting to avoid transparency. A CDC official discussing the sharing of vaccine safety data stated, quote, I think because of the FOIAs, we may have asked FDA to stop sending these weekly data mining outputs, unquote. In spite of their concerted effort to conceal what they knew and when they knew it, documents we've retained, thanks to Secretary Kennedy's responsiveness to my subpoena and his commitment to radical transparency, paint a clear picture of an obvious cover-up by federal health officials. Our report shows how FDA officials were warned and fully aware of their safety surveillance system's inability to adjust for a statistical phenomenon called masking, which according to medical researchers occurs when, quote, signals for a vaccine of interest are hidden by presence of other reported vaccines, unquote. Rather than use a newer state-of-the-art system that can adjust for masking, Biden health officials purposefully chose to employ the older system that conceals the signals for serious adverse events associated with the COVID injection. Throughout 2021, FDA officials received multiple analyses from the state-of-the-art system showing statistically significant safety signals for adverse events, but made a conscious decision to ignore that data. On October 22, 2020, CDC's Tom Shimbakuro touted VAERS by saying it can, quote, rapidly detect safety signals and can detect rare adverse events, unquote. But in an email a year later, when VAERS was reporting worldwide adverse events of 837,595 and 17,619 deaths, Dr. Shimbakuro stated, quote, it's not a database that should be used for serious surveillance and research. And we have up on the screen a chart that I produced almost weekly once I started tracking this. And you'll notice it compares different drugs, adverse events reported, those things, deaths per year. You can see at the top of the chart, ivermectin appears to be a pretty safe drug. At the very bottom, COVID vaccines, and again, this is in October of 2021. 17,619 deaths. It's important to note that 32% of those occurred either on the day of vaccination or within 1 or 2 days of vaccination. I know VAERS doesn't prove causation, but that is a correlation that federal health officials ought to be looked at. In reaction to the skyrocketing number of deaths and adverse events, other Biden administration and federal health officials were also publicly denigrating VAERS with comments like, quote, falsified VAERS report, potentially misleading VAERS posts, frequently misused by anti-vaccine activists, and, quote, conspiracy theorists, science deniers, and anti-vaccine activists can fill out the form. Now, this is quite honestly contrary to reports in terms of the high percentage that are actually reported by medical professionals. The federal health agencies had to be sued twice before a court finally forced them to disclose the results of the VSAE system, an online self-reporting safety for surveillance system created specifically for the mRNA COVID injections. Here's why they fought so hard to keep that from public view. Of the 10 million people who voluntarily provided information to VSafe, 7.7% sought medical care for COVID injection adverse events, and 25% lost time at work or couldn't perform their daily routine following injection. Even though I wrote 21 letters requesting information on what the agencies were tracking and what they knew about adverse events, I didn't need sophisticated mathematical models to tell me the COVID injection was causing significant harm. The data depicted on these charts alone should have raised the alert level to DEFCON 1. Now, this first chart is showing deaths reported on VAERS since the inception of VAERS. You can see starting in 1990, deaths were approximately a couple hundred per year, anaphylactic shock, those types of things. In 2021, deaths spiked to 21,631. Now, again, I didn't need a mathematical algorithm to tell me there's something going on here. And by the way, a lot of people will say, well, that's because we administered billions of doses. One of the letters I wrote to the CDC showed the rate of death per dose, compared it to the flu, which is about 0.46 deaths per million doses. Time we calculated this, the COVID injection was 25.5 deaths per million doses. That's a 55-fold increase over the deaths for the flu vaccine. So something was going on here. Our federal health officials should be paying attention. Let's do the next chart. This is the most up-to-date VAERS chart now. It's showing 39,077 deaths worldwide reported to VAERS. And understand, and we'll be adding this to the record, the Pilgrim report. An HHS-funded Pilgrim study at Harvard University showed that adverse events for vaccines are reported at less than 1%. So this grossly understates the number of adverse events and deaths, and you can see adverse events are almost 1.7 million. Multiply that times what, 100, 30? These are dramatically understated. In spite of these shocking numbers, federal health officials continued to recommend the injection, claiming it both safe and effective. By comparison, in 1976, after approximately 25 to 30 deaths and over 500 cases of Guillain-Barré syndrome, the swine flu vaccine was pulled from the market. Biden federal health officials were clearly not as vigilant in reacting to what VAERS was showing. For over 4 years, I have wondered how health officials could possibly ignore this overwhelming evidence of harm. Now I know. Our report details that on March 1st, 2021, less than 3 months after the COVID injections received an emergency use authorization, Peter Marks, the head of CBER, and officials reporting to him were warned by FDA's Dr. Anna Scharfman, and an individual who these officials recognize as an expert in FDA's data mining, that the current system would mask safety signals for COVID injection adverse events. Dr. Scharfman proposed a new model, a new method, invented by Dr. William Dumichel of Oracle, the inventor of the current algorithm, to uncover the hidden safety signals. On March 26, 2021, 26 days later, Dr. Scharfman sent Dr. Dumichel's data analysis to senior FDA officials, showing that the new analytical method found, quote, 49 examples of extreme masking and uncovered approximately 25 statistically significant safety signals of adverse events associated with COVID injection, including, let's put up the next chart here. Here's the sheet. These are the adverse events that they were showing a safety signal for using the new method: Bell's palsy, sinus rhythm, cardiac failure, chronic, acute left ventricular failure, agonal rhythm, which is severe arrhythmia generally occurred at the end of life, pulmonary infarction, cerebral artery occlusion, aortic stenosis, sudden cardiac death, hypertensive emergency, basal ganglia stroke. Now these aren't minor. Remember, we're always told, adverse events are rare and minor. These are not minor adverse events, and these safety signals were showing, and they were strong, but they were being hidden because FDA officials refused to acknowledge that the current system they were using was invalidated. And they had to look at the new system that unmasked these things. Our report goes on to detail how federal officials refused to acknowledge these revelations or take action to warn the public. Instead, senior FDA officials repeatedly tried to stop Dr. Scharfman from continuing her work or communicating her findings outside of FDA. In September 2021, Dr. Marks informed Dr. Patricia Cavazzoni, the then director of CDER, that Dr. Scharfman, who was a CDER employee, quote, has been asked to cease and desist conducting her data analysis. Dr. Marks complained that Dr. Scharfman's work had become, quote, a major distraction, that her efforts could create erroneous conflicts that feed to anti-vaccination rhetoric. Dr. Peter Stein, the then director of CDER's Office of New Drugs, reported to Dr. Marks that his office had, quote, made it clear to Dr. Scharfman, quote, that she should not be discussing and providing internal analyses externally and needs to focus on her assigned work. Dr. Scharfman, who retired from the FDA in 2025 after more than 35 years of service, told PSI staff in a recent interview that she believed her FDA colleagues saw her as a, quote, pest and, quote, persona non grata, unquote, because she was raising concerns about masking. Our witnesses today are medical researchers and experts in scientific data collection. They will help clarify the masking issue and describe why this cover-up was so egregious. I want to thank them for their time and effort they put into our testimony. I also want to thank Secretary Kennedy for his commitment to radical transparency and for promising to make HHS personnel with knowledge of these events available for interviews with subcommittee. And I also want to give a huge shout out to my staff. These are the folks who found a needle in a haystack in a document production from one of the universities that we were investigating 2.5 years ago. Found that David Morin's email where he was talking about being able to, being told how to make emails disappear and to use his Gmail. So these are the folks who did that, and these are the folks who have combed through 11 million pages to find and discover this egregious cover-up.
Amid everything that's been said, I think we ought to remember what it was like during the height of the COVID pandemic. Literally, the fear, the death, the loss, and then the relief as a result of Operation Warp Speed, which President Trump ordered, in having a vaccine that gave people hope and many people life. At the same time, none of the relief or hope enabled loved ones to come back. They lost lives, and families had their lives upended. And we can never forget the heroes in our healthcare system who braved COVID in delivering care to people who needed it in hospitals, many of them for weeks, sometimes months. We are fortunate to have with us Maria Young. Thank you for coming here today, who spent many days in a hospital, close to 70 days in intensive care. Most lives were forever changed as a result, but the vaccine offered a path forward for so many people, and we should be thankful for Operation Warp Speed. In January 2021, more than 20,000 Americans were dying each week from COVID-19. Between 2020 and 2025, more than 1.2 million Americans lost their lives to COVID-19. That's 1.2 million parents, children, friends, loved ones. And those deaths changed not only their families, but their communities and our nation. Husbands lost wives, parents lost children, and in addition to those who perished, millions were infected and many of them suffered life-changing injuries from the virus. And employers suffered economically, as did our overall economy. And the survivors still bear, many of them still bear the scars of that experience emotionally, if not physically. Years of scientific analysis have shown that COVID-19 vaccines saved lives and prevented serious illnesses like the one that Ms. Young suffered. I don't agree with President Trump on a lot, but I have to give him credit for the work that was done to create COVID-19 vaccines in record time. But instead of talking about the success and remembering the ones we lost, vaccine opponents have turned one of the greatest scientific breakthroughs in our country's history into fodder for political attack. I don't get it. Today's hearing purports to discuss a cover-up of side effects of the COVID-19 vaccine, as if serious flaws in vaccines were purposely ignored. And let me be clear, they were not ignored. They were not disregarded. They were not covered up. The majority's report cherry picks emails and misconstrues an internal debate between scientists who were actively looking for ways to detect side effects to support a predetermined and flawed thesis that COVID-19 vaccines have done more harm than good. That's not the scientific method, to have a preconceived result and then frame the evidence to fit the outcome. The report and documents that the majority has released simply do not support the notion of any kind of cover-up, nor do the reports and documents do anything to change our understandings of the vaccines as safe and effective. These points are important for the public to understand. And with all due respect, nothing that Chairman Johnson has released shows the vaccines were linked to any adverse effects beyond the rare ones that health officials have acknowledged. Indeed, the risk of stroke he claims was hidden not only was studied openly, but later shown not to exist. Without objection, I would like to enter into the record the 4 studies demonstrating that COVID-19 vaccines and boosters save lives, Mr. Chairman.
Without objection.
There is also a really deep irony in the majority's argument, given the current administration's overt effects to skew science and undermine public health. Last week, I wrote to the acting CDC director, Dr. Jay Bhattacharya, about reports that he has blocked publication of a recent study showing that COVID-19 vaccines were extremely effective at preventing hospitalizations last winter. That study still has not been formally released, although I understand that a copy was somehow leaked, literally hours before this hearing, magically released, but not officially. And therefore, I call on the CDC director to officially release that report. Again, I asked my letter to him to be entered into the record if there's no objection.
Without objection.
I sincerely hope we never face another pandemic. I think most Americans join in that hope. And that we are still able to find dedicated scientists and, yes, pharmaceutical companies willing to work around the clock to find vaccines and cures, and public officials who are willing to support and encourage and to fund them with resources. I fear that this administration's actions to politicize science and slash scientific funding and to expel talented scientists are doing irreparable harm to our nation's ability to counter the next pandemic. The threat remains real and present, and we must respect science and encourage our scientists to continue to do their work.
Distinguished Chairman, Ranking Member, and committee members, with today's stunning revelations, I am humbled to discuss critical flaws in statistical safety signal and potential risk detection in VAERS, touted by CDC as the nation's early warning system for vaccine safety, and credited by former CBER Director Marks with detecting both potential and actual safety issues and informing vaccine policy decisions. Among limitations undermining detection of statistical safety signals is the problem of masking. Masking occurs when statistical signals for one vaccine in a database are obscured by reports associated with other vaccines. For example, Moderna's myocarditis signal becomes hidden if its comparison baseline is artificially inflated by including Pfizer's myocarditis signal reports. In a simple analogy, hemlock and arsenic appear equally toxic when compared separately with a non-toxic baseline control such as tea. However, if hemlock's baseline data include arsenic data, hemlock's signal is drowned out or masked, appearing innocuous. Today's report shows that senior FDA staff were apprised of the masking problem both prior to COVID vaccine rollout and repeatedly by Dr. Anna Schaafman. Dr. Schaafman is a veteran FDA statistician lauded for bringing the empirical Bayesian method into FDA after collaborating with its inventor and developer of the associated Empirica signal software, Oracle's Dr. William Dumichel. Schaafman communicated Dumichel's findings of extreme masking, including death, myocardial infarction, stroke, and dementia, noting that I am not astonished that FDA's analysis was unable to detect these signals. She repeatedly advised colleagues of Dumichel's improved procedures, not brand new, they'd been around a while, to address masking in the same Empirica signal software used by FDA and commercially available. Nonetheless, officials attempted to contain Dr. Schaafman, asking her to cease and desist. Elsewhere, officials claimed ignorance on how to address masking and that developing solutions exceeded FDA's capabilities, considering it problematic to use a brand new, possibly unvalidated tool in the context of an EUA. FDA had validated methods adaptable to demask signals. In a special data run in the new documents, FDA's Dr. Menschik found a muting trend yet to appear in the record. In the related PRR, or proportional reporting ratio analyses required of them by the VAERS standard operating procedure, CDC somewhat accounted for masking. In 2022, Schaafman and Dumichel published in the leading journal Drug Safety their masking concerns and the improved method, unmasking hundreds of statistical signals for the COVID vaccines, consistent with my analysis. Despite possessing both software and in-house expertise, regulators failed to implement this solution to correct for masking, a striking failure given the accelerated population scale deployment by Operation Warp Speed of a novel and most complex class of drugs ever, mRNA. Compounding further, CDC considered that its PRR analyses were rendered basically redundant by FDA's Bayesian work, discarding its responsibility to generate these PRRs. Accordingly, the United States lacked a fully functional early warning system at the time of its greatest need. Separately, statistical signals were trivialized by avoiding the terms signal or potential safety signal. These failures are incompatible with the so-called enhanced surveillance required by VAERS standard operating procedures. Hindering investigation of potential risks, FDA was obliged to consider even without having to prove causality, and impugning vaccine injury compensation, authorization, and approval decisions, principle of which was Comirnaty's hastened full approval undertaken while Dr. Schaafman was voicing her concerns. Further, they marginalized those apparently injured by COVID vaccines. Not only did the system fail to perform as advertised, but as the drug safety paper presciently warned, the COVID vaccine reporting deluge likely created masking effects that now compromise signal detection for other vaccines going forward, and there are several papers that describe this. Regulators must swiftly correct masking and other VAERS deficiencies, heeding earlier warnings of their former colleagues, Drs. Marks and Jernigan, who said, failure to detect and communicate a serious health issue related to vaccines could impact confidence not only in COVID vaccines, but in all vaccines.
Pharmacovigilance is absolutely necessary. Our knowledge is limited, even of a vaccine that passes clinical trials of a few thousand very healthy people. We simply do not know what adverse events look like in a diverse, large population until they're administered to a diverse, large population. We had better be watching very closely, which is pharmacovigilance. The vaccines, by honest accounting, were pathetically tested. Pre-EUA, no drug-drug interaction study, no cardiovascular toxicity, central nervous system toxicity, other organ toxicity, blood toxicity, genotoxicity, carcinogenicity. Had they actually turned out to be safe, it would have been serendipitous, a happy accident. Luck is not a pillar of public health. Pharmacovigilance behind closed doors should give everyone pause. It is simply too important to not do it correctly. Lapses can be and were catastrophic. The vigilance heavily depends on three sources of data: the passive surveillance of VAERS, the active surveillance of vSafe, and the VSD, an active system linked to medical records. vSafe was designed to collect inconsequential data. One of the first papers to publish it was a mortality and adverse event study. The only figure in the entire paper was a time series comparison for both Moderna and Pfizer, for both dose 1 and dose 2 of adverse events no one cares about. Injection site pain, fatigue, headache, myalgia, chills, and joint pain. Dr. Renata Engler is distinguished in the study of vaccine-induced myocarditis among U.S. military with 4 publications on the smallpox vaccine. On the CDC not including myocarditis in vSafe, she asked, if you do not ask, you will not see it. But does that mean it does not exist? Within 50 days of that meeting, Dr. Engler would start adding 4 more publications on COVID-19 vaccine-associated myocarditis. The CDC already had in hand Israel's slides. The vSafe system had 10 million volunteers. About 1/3 entered free text. Perhaps there is some horror found in the 366 individuals who typed in myocarditis, a condition requiring medical diagnosis. That is amplified by the nearly 50,000 people who typed in chest pain. The Vaccine Safety Data Link is a collection of 13 healthcare organizations covering 15.5 million people. It can detect safety issues within a few weeks. Most frequently used is rapid cycle analysis, which can miss delayed onset events. Better and timely options, like the vaccinated versus unvaccinated or pre-post, is rarely used. And they would need the well-practiced extra step of considering differences in healthcare-seeking behavior. By the time the CDC's webpage was updated to warn of inflammation of the heart, 313 million doses were administered to 173 million people. I do not see vigilance at work. With VAERS, the CDC chose to ignore its own standard operating procedure and not run proportional reporting ratios in favor of the FDA's, what Walensky calls more robust and Shimabukuro calls the gold standard. VAERS had been grossly underreported for the first 30 years, maxing out at 58,000 reports. In its 31st year alone, VAERS logged 18 times that number. Because of this disproportionality, the FDA's disproportionality analysis was washed out. Since both vaccines were of the same platform and same adverse events, the comparison was muted. This isn't a blind spot. The FDA was completely blind to adverse events, and the CDC wasn't even looking. There was a savior in the ranks of the FDA who correctly identified the problem, appropriately worked with the inventor of EB data mining to create a solution, communicated the fix to everyone who would listen. The problem is, no one listened. Luck was not on our side. The CDC failed to look. The FDA failed to fix a broken system that the CDC touted as the gold standard. The HHS failed to protect us, especially after our freedom of choice was assaulted by the president threatening us all with, "Our patience is wearing thin." FOIA evasion was well practiced and discovered, obviously, not through a FOIA. Simply put, during the largest pharmaceutical rollout in human history, pharmacovigilance did not exist. That is the betrayal of our time, so vast that we cannot even count its casualties.
Thank you. My name is Maria Young. Thank you to the committee members for inviting me to share my story today. Survivor, warrior, miracle. These are all words that have been used to describe me over the last 5 years. They aren't words I would have chosen for myself. For me, I was just trying to regain the life I had lost to COVID before we had vaccines or any possible treatments. In 2020, I went from being a healthy, active woman with a full career to being sedated, paralyzed, and placed on life support within days. I became a survivor of severe COVID-19, ARDS, acute respiratory distress syndrome, after spending 69 days on ECMO, extracorporeal membrane oxygenation, and 70 days on a ventilator. I am here because survival is not the end of the story. For those unfamiliar, ECMO is a rare form of life support, used when the lungs can no longer function on their own. Blood is removed from the body, oxygenated by a machine, and returned. It is invasive, complex, and used only when all other options have failed. ECMO does not heal the lungs. It buys hope and a little time. But that hope comes with significant risks: stroke, neurological injury, blood clots, infections, limb loss, organ failure, and of course, death. I spent more than 4 months in the hospital, most of it in the intensive care unit, ICU, most of it in a medically induced coma, and most of it alone. When I finally woke up, I had no memory of the time that had passed and no understanding of how much I had lost. During those months, my family lived through trauma that still echoes today. My mother was told repeatedly that I was not expected to survive. My sister wrote my eulogy. My family prepared themselves for the unimaginable, all without being able to see me in person. Day after day, my mother waited by the phone for a call from my doctor with the update for that day. They carried grief and hope at the same time, a burden that families of critically ill patients know all too well. While I was unconscious, my body endured a long list of complications that many ECMO survivors face. Multiple infections, including one that almost took my vision, blood clots, collapsed lungs, severe muscle wasting and deconditioning, delirium and hallucinations, prolonged sedation and sedation drug withdrawal, blood transfusions, a tracheostomy, a feeding tube, pressure wounds, a deep neck wound from cannulation, and long-term cognitive and physical impacts. These complications are not footnotes. They are the reality of surviving critical respiratory illness. They shape recovery for months and often years. They are especially hard when the diagnosis and treatment lack understanding and support. When I finally woke up, I had to relearn how to breathe, how to swallow, how to sit up, stand, and walk. I had to rebuild my life from the ground up. And while I'm deeply grateful to be alive, gratitude does not erase the trauma. Survival comes with weight, the weight of knowing how close I came to dying and that many others weren't as lucky. When I was discharged, my list of diagnoses included dysautonomia, cognitive impairment, demoralization, severe body deconditioning, long COVID, partial vocal cord paralysis, and post-intensive care syndrome, among others. But alongside that weight is profound gratitude. Gratitude for the nurses who spoke to me even when I was unconscious. Gratitude for the respiratory therapist who taught me how to breathe again. Gratitude for the physical and occupational therapists who celebrated every inch of progress. And gratitude for the doctors at Johns Hopkins who made bold decisions to save me, including placing me on my stomach while on ECMO to try to improve my lung function and oxygenation, something that had never been done before at Johns Hopkins on a patient on ECMO with a tracheostomy. They believed my life was worth fighting for. And gratitude for my community, who held my family up when they could no longer do it on their own. My experience led me to advocacy. Over the last several years, I've connected with hundreds of survivors, people living with long COVID, families who lost loved ones to COVID-19 or while on ECMO, and ECMO survivors who carry scars both visible and invisible. These communities are full of people who fought for their lives or for their loved ones' lives, and emerged in a world that often moved on without them, many feeling abandoned by systems not built for long-term recovery, by insurance structures that don't recognize the complexity of a post-ICU life, and by a public narrative that treats survival as the end of the story. My work is to make sure they are seen, heard, and supported. That's why I stay up to date on my COVID boosters and other vaccinations. I also continue advocacy with organizations like Vaccinate Your Family to share my story through them, through my personal connections, and encourage everyone to continue to get vaccinated against COVID-19 and other diseases in the hopes of helping people avoid the same traumatic experience I and my family went through or worse. Survival should not be followed by fear. It should be followed by support, protection, and a chance to rebuild a life with dignity.
I want to, once I introduce this video, I want to start my Q&A with a 1-minute video. But to set it up, this is a video of recordings of Zoom calls between the vaccine injured. And by the way, React 19, I think I read, they've got something like 40,000 active members. They probably would have more if Facebook hadn't been shutting down their support groups, leading to suicides among those, lack of that support. But this is actually a note in terms of what this video describes here from Breanne Dressen. She writes, beginning in March 2021, seriously COVID-19 vaccine-injured patients were flown to NIH, and this is March 2021, the same time they were made aware of the fact that they were going to mask the safety signals using the algorithm. Vaccine-injured patients were flown to NIH headquarters for extensive testing and evaluation and treatment. Study participants, and I think there are about 23 of them. Study participants received credible diagnoses, including, quote, post-vaccination neuropathy. Again, they were diagnosed as vaccine injured. And specialized treatments the participants say saved their lives. They were incredibly grateful that the NIH, people like Dr. Nath, were paying attention to them and treating them and improving their severe injuries. That same month, NIH researchers began promising participants that the study and their injuries would be made public. And apparently the email where that promise was made was also copied to Peter Marks and acting FDA Commissioner Janet Woodcock. The NIH then asked participants to remain quiet, say nothing, until they disclosed the study themselves. They complied. They feared if they were to go public, they'd lose the treatment, that all the thousands of other injured that were counting on them to be studied to develop cures wouldn't receive treatment either. So they stayed silent, holding on to the promise that help is coming for the many others nationwide. That study and the injuries were never disclosed to the public. They were lied to. And this video, again, read my report. Senator Bloom, I cannot believe you read my report based on your opening statement. Read my report. It is irrefutable. But the video is of Peter Marks, head of CBER, the man who was notified on March 1st, 2021, that the safety surveillance system that they were going to use to detect those rare and mild safety signals was invalid. It was going to mask those. It was going to hide those very safety signals. Again, 26 days later, a state-of-the-art system showed 25 safety signals, and I read how severe those adverse events were. But just listen to what Peter Marks, with the knowledge that he was treating vaccine-injured, and they weren't mild injuries. These were life-threatening injuries. These were total disability type of injuries. So he knew it. He was treating them. He knew that his safety surveillance system was masking these signals. They lied to them. Listen to what Peter Marks had to say. This is about a minute-long video.
There is incredible BS out there about like thousands of people dying, etc. That just ain't true. No one's denying that adverse events can occur. That doesn't mean that any given individual might not have had something related to the vaccine. I'm not denying anything. The issue is that the number of cases have not risen to a number that leads to a clear differentiation that it's a signal. There's not a clear signal. It just says that we don't have a signal. We continue to query the various databases. The large databases still have not seen a signal. You couldn't really tell. You just couldn't tell whether there was a signal or not. It's something that's been reported, but not as something that is clearly vaccine related.
You guys know we exist. We know that you know that we exist, but the public doesn't think that you guys know that we exist.
That was Brianne Dressen at the very end there. Again, they were pleading with the officials at the FDA, NIH, that knew they were severely injured by the vaccine, counting on them to make that public, to study their results so that others could get treated. To this day, they have not done that. Put up chart number 2 here. Again, I know you've looked into this in a great deal of depth. You know, probably the very complex mathematical models and algorithms of empirical Bayesian analysis. I'm not a statistician. I'm just a lowly accountant. How in the world could the people who were touting VAERS, Tom Shimabukuro in October of 2020, this is a system that can really detect even small safety signals. They had to hire the contractor that was putting VAERS, the VAERS reports into VAERS. They had to hire thousands of more people because of the overwhelming numbers of reports. Did you need a fancy statistical algorithm to tell you that something was going wrong here with these injections?
Yeah, clearly there's some big alarm bells that are going off there. But I do want to point out that, one of the criticisms of VAERS is that, that stimulated reporting and anyone can report and all that sort of thing. The point about these disproportionality analyses is that it actually removes that from the equation because of the way the mathematics are done. So obviously there's red flags in that sort of chart that you're showing there. But the key point about these disproportionality analyses, the Bayesian data mining, the PRR, and others, is that it actually removes that from the equation because of the niceties of how the mathematics are done. So that's really important. So in the list of 49 events that you've listed there, these are all showing signals for the Bayesian data mining, and also not only that, in the PRR method, which is masked. They're showing signals. So whichever way you look at it, there's signals. And the key point, Senator, is that for the purposes of the EUA, the FDA will require to consider not only actual proven risks, but potential risks. And potential risks are represented by signals without necessarily having to prove causality. But in all the decisions, the law is very clear. It says that FDA has to consider actual and potential risks. And by hiding the potential risks in the various ways that you've described, the public were deprived of this knowledge, the doctors were deprived of the knowledge, the ACIP and the VRBAC committees were deprived of this knowledge. So every way you look at it, there's a problem.
So again, so my sophisticated mathematical model, when people push back on this, well, yeah, Senator, it's because we had billions of doses. So we calculated deaths per million doses, compared that to the flu. Again, that's disproportionate, right? Disproportionality. So flu averaged about 0.46 deaths per million. When we did the calculations, 25.5. That's pretty disproportionate to me. Throw
right.
on, combine it with that. Again, you don't need, they didn't need.
Well,
and again, then they had the vaccine injured in front of them. They were treating them. They are diagnosing them, not with mild, but with life-threatening injuries. Dr. Jablonski, how do you answer that?
Several years ago, Dr. Brian Hooker and I did an analysis of VAERS when we tried to pinpoint when enough VAERS reports had existed to identify myocarditis. And that dates all the way back to the week of February 19th of 2021, which is well before even Israel contacts the CDC saying, we're seeing a whole lot of myocarditis. We want to speak with a relevant expert at CDC. It is way before anyone in the United States that the CDC admitted to them on May 28th.